Degenerative disorders of joint and related tissues. For the normal aging of articular cartilage in young person, there is a smooth and glistening surface of the articular cartilage. Later in life, the articular cartilage becomes granular and has a dull surface. There is a very limited ability to regenerate, and there is a degenerative changes tend to be irreversible and progressive. Biochemically, there is a gradual loss of proteoglycan as the matrix deteriorates. The collagen fibers lose their supports and the cartilage tends to become shredded. The result becomes less effective and more vulnerable to intermittent load-bearing and repeated friction of normal function. In premature or with excessive foot pain, there is a degenerative joint disease. Osteoarthritis. Degenerative joint disease or osteoarthritis, it is a common disorder of one or more joints. It is initiated by local deterioration of articular cartilage. There are osteoarthritis, osteoarthrosis, degenerative arthritis, senescent arthritis, and hypertrophic arthritis. The incidence is the most common type of arthritis. After the age of 60 years, 25% of women and 15% of men have symptoms related to OA. After the age of 75 years, more than 80% of women and men are affected. The primary type or the idiopathic type is more common in adult women. The secondary type is more common in adult men. Wear and tear involves most common in weight-bearing synovial joint. Etiology. In primary idiopathic degenerative joint disease, it is due to normal aging process in cartilage, where there is a continued abuse and obesity. In secondary, which is more common than the primary type, there are injury, deformity, and diseases that are capable of producing the initial cartilage lesion. It is more common in weight-bearing joints of the lower limb. Pathogenesis and pathology in synovial joint. Whether primary, secondary, or both, the process in the early stages is similar and represents a significant exaggeration of aging process. In articular cartilage, the earliest there is a biochemical changes. There is a loss of proteoglycan from the matrix that result in chondromalacia and loss of the normal elastic resilience. Collagen fibrils having lost supports and unmasked, therefore it is more susceptible to the friction of joint function. There is a fisturing and fibrillation. The pictures of fisturing and fibrillation is shown in this slide. The cartilage becomes more cellular to compensate loss of proteoglycans and collagen at a greatly accelerated rate. However, the total content of proteoglycan is diminished due to progressive destruction by lysosomal proteases and neutral metalloproteinase. In articular cartilage, there is also vascular invasion to the abnormal cartilage. In the central area of joint surface, the cartilage is gradually abraded down to subchondral bone. In the peripheral area of the joint, the cartilage responds by hypertrophy and hyperplasia to form a thickened rim of cartilage around joint margin. The result of both is the incongruity of the joint surfaces. In subchondral bone, Normal subchondral bone is stiffer than cartilage but more resilient than dense cortical bone. Normally function as a shock absorber. In the central area of maximum stress and friction, there is a herniated and hypertrophied. In the peripheral areas of minimal stress, there are atrophies and less dense, or osteoporotic. If there is an excessive pressure, particularly in weight-bearing joints, it leads to the development of cystic lesions within the subchondral marrow. The biomechanical redistribution leads to a remodeling of the subchondral bone. Synovial membrane and fibrous capsule. Small fragments of abraded dead cartilage may afloat in the synovial fluid as loose bodies, but tend to become incorporated in the synovial membrane, undergoing hypertrophy and producing a moderate synovial effusion. Therefore, there are more mucin and more viscous. The fibrous capsule become grossly thickened and fibrotic, further limiting joint motion. Muscles. The muscle controlling the affected joint develops spasm in response to pain. The flexor eventually undergo contracture, resulting in joint deformity and further restriction of joint motion. There is also limited joint motion that leads to excessive stress are applied to limited area of joint cartilage. Therefore, there is a exaggerated process of degeneration. The late result is fibrous ankylosis of the joint and bony ankylosis. Clinical features and diagnosis. There is no systemic manifestation, only local to individual joint. The main symptoms is pain. At first, dull ache and later more severe. It is intermittent and aggravated by joint movement. Eventually, there will be resting pain. The pain is worse when barometric pressures falls just before a period of inclement weather. The severity of pain is not equal to the severity of degenerative joint disease. Clinical features and diagnosis. Other symptoms is there is no longer smooth joint motion, joint crepitus, and later joint stiffness after period of test. In a physical examination, there is a swelling of the joint, relatively little synovial thickening, and no increased warmth. Active and passive ROM are restricted. This is a radiographic changes of degenerative arthritis. Radiographic, there is a narrowing of the cartilage space, subchondral sclerosis and kyst, osteophyte formation, and joint remodeling and incongruity. Lab, there is no evidence of systemic disease. In synovial fluid, there is an increased mucin content and viscosity. You should always determine whether the disease is primary or secondary. Prognosis. Although virtually all persons experience some degree of degenerative disease in one or more joints, it is usually mild and there is also annoying discomfort. When severe and continuous usage, there is a progressive deterioration and increasing pain and loss of motion. In lower limb, has a relatively bad prognosis due to continuing demand when walking. Treatment, there is no specific cure. The aim of the treatment is to help the patient understand the nature of disease, to provide psychological support, to alleviate pain, to suppress the inflammatory reaction, to encourage the patient to remain as physically active as possible, to correct existing deformity, to improve function, to strengthen weak muscles, and to rehabilitate the individual patient. Therapeutic drugs is salicylate, NSAIDs. Narcotics or systemic steroid is of no value, and there is a local injection of intra-articular steroid. Orthopedic appliances combined with general rest, localized rest with removable spline is of value. Cane held in the hand outside opposite the affected hip or knee. Physical therapy, active movements of involved joint within the limits of pain. Local heat with heating pad, infrared lamp, and so. Orthopedic surgical operation. Prophylactic is the arthroscopic debridement and irrigation. However, it is no longer recommended. Surgical correction of joint conditions. An example, marked univarum or varum. Residual congenital subluxation of the hip. Therapeutic should be considered at a relatively early stage. Types is osteotomy, arthroplasty, arthrodesis, soft tissue operation, transplantation of partial joints, and experimental method. Surgical treatment of degenerative joint disease in specific synovial joints. Foot and ankle. MTP of the great toe without deformity, hallux rigidus. Local treatment, arthrodesis or resection, arthroplasty. Can also develop from long-standing deformity such as hallux valgus. Ankle and dorsal joint usually secondary to residual deformity, arthrodesis of the involved joints. Knee. The initial site is the articular cartilage of the posterior surface of the patella. It is characterized by malacia, fisturing and fibrillation of the cartilage. The most common typical symptoms is retropatellar pain, aggravated by going up or down stairs and running. Non-operative is with regular quadriceps exercise or salicylate. Operative is the lateral compartment of the knee, long-standing genivalgum with closed wedge supracondylar osteotomy of the femur. Medial compartment of the knee or long-standing genivalgum is with closed wedge osteotomy of the upper end of the tibia. If there is an evidence of both, then unicompartmental replacement arthroplasty is done. Hip, one of the most challenging clinical problems. Primary idiopathic, relentlessly progressive and disabling. Young adult with residual DDH. Older adult is a total excision of joint and prosthetic joint replacement. Hand and wrist. Herbidens note. Often causes no deformity and ignored. OA at first carpometacarpal joint at the base of thumb may require arthrodesis. Usually secondary to trauma, less commonly to AVN of the lunate. If no response with non-operative treatment, therefore arthrodesis of wrist in functional position of slight dorsiflexion. Elbow, almost always of the secondary type, frequently post-traumatic. When limited to the radiohumeral joint, excision of the radial head. When entire joint is destroyed, prosthetic joint replacement. Shoulder. It is not common but disabling. Early stages, there is a soft tissue operation with division of the coracoacromial ligament, transection of the subcapsularis muscle, and capsulotomy of the joints. For severe stages, prosthetic joint replacement, AC joint involvement, excision arthroplasty.